peripheral vascular disease. All right. I'll tell you a very, very, very quick story. Years ago, my father-in-law had severe cellulitis. I don't know if any of you have ever taken care of patients with cellulitis and in his lower extremities. And it was, every month he was coming down with a condition where he needed an antibiotic because his legs were extremely large, inflamed. He was, I don't know, I think he was like in his upper 80s at the time. He had had a stroke, so he wasn't able to get around at this point. Anyway, they were putting him on antibiotics all the time. So he went to see Dr. Sims over at St. Mary's Hospital. He's head of infectious disease. And Dr. Sims told him, instead of putting him on an antibiotic, which of course he's only a fan of antibiotics when needed, he does not like to use them excessively. But my father-in-law was getting so many infections. So Dr. Sims told him to use compression stockings. And he said, "Oh, I don't like to use them. They're too warm. In the summertime, they're too warm on my legs." And so he said, "Well, if you want to solve the problem so that you don't get cellulitis chronically, which can lead to other conditions," he said, "use the compression stockings." So he used the compression stockings and he never got another infection. And that's a true story. So I'm a huge fan of compression stockings. They really protect your legs, especially those people, us working in the hospital, standing all day long, really important to use. Okay, peripheral vascular disease. Yeah, they're great. And plus, I'm always cold, so I like them because they keep me warm. Anyway, all right, so I'm not going to get into tissue perfusion. We talked about it yesterday. Here are the objectives. We're going to talk about peripheral vascular disease, the causes of it, risk factors, how we can prevent it. You all know how we can prevent it, okay? Exercise, ambulate our patients, normal exercise routine. What are the clinical manifestations? What does it look like? We're going to be comparing and contrasting arterial and venous disease. Very, very important for you to figure out, differentiate. Is this an arterial problem or is it a venous problem? Because they're two different things. And I can't stress that enough. Know if it's arterial or venous. Which way is the blood going and what is the problem in the blood getting to the extremity or returning to the heart? All right, and the common diagnostic tests and labs used to diagnose a patient. We're also going to be talking about osteomyelitis and amputation. Osteomyelitis is the exemplar. So there are definitions here that I think you guys have all learned and looked at. They are peripheral vascular disease. When we say peripheral vascular disease, and most people do, I think of it as both, it's vascular, but for the most part, they refer to it as peripheral arterial disease, the arterial system of the blood moving with lots of oxygen, right? It's gone to the lungs, out the aorta, and it's going out to the body with nice oxygenated blood. And it's going through the arteries. So this is peripheral vascular disease, is peripheral arterial disease as well. Sclerosis, which is hardening of the arteries. Athero, that means an excess of cholesterol and fat deposits. These definitions are all in your book. Arteriosclerosis, so think of arteries, so it's a loss of elasticity of the arteries. Atherosclerosis, it's hard to say some of these. That's a type of arteriosclerosis, and that's where you have the fat and fibrin, and they can obstruct the hardened artery. So sclerosis, hardening. Chronic venous insufficiency. So this is a condition where you have inadequate venous return. So this is the venous system versus the arterial. Venous system is returning the deoxygenated blood to the heart. So that's where you can have this over a period of time. Maybe it's a valve problem. It can be a hereditary problem where you can just have chronic venous insufficiency. Intermittent claudication, that's where you get, we're going to talk a little bit more about that, but claudication is cramping or pain aching in your calves, your legs, and your thighs and your buttocks that occurs with activity. When you walk for a long period of time, your legs might start to hurt and you're going to get that cramping. And that is quite, it's almost kind of like when we talk about dyspnea on exertion, where you need more oxygen to your lungs when you're moving around and you get short of breath, right? If you run a mile or you run, some of you may, maybe like 500 feet down the road and you get dyspneic on exertion. It's almost the same kind of thing, except it's with your legs and you get pain. On exertion, when you start taking a walk, you get pain in your legs when you're moving around. And that occurs with activity. And the reason for that is because as the blood is moving down your vascular system, you require more oxygen. And when you're requiring that increased amount of oxygen, your vessels require it. And maybe there's a problem with it. So if you have a problem with peripheral arterial disease, or PVD, I'm going to use the two interchangeably. PVD and PAD, same thing. So if you have a problem where maybe you've got a narrowing in that vessel, the blood is not able to flow and you're trying to move around quickly and the blood is not getting down there, you're going to get pain for the amount of activity. So you have to stop. Okay? It's in the book. You can read a little bit more about it too. So what happens with this? You get fat, fibrin, hardened arteries, plaque forms in the bifurcation. It obstructs the blood vessel. So the blood is, so when you're going to get decreased blood. If the blood is trying to go down to your feet, okay, it's heading south. Remember, you got to think about what direction. It's heading south. So you have decreased blood flow if you've got obstructions in that blood vessel. So you got plaque in that blood vessel, you got something in that blood vessel, you're going to obstruct. There's going to be a blockage on the highway. You got a traffic jam. So it's going to be equivalent to tissue hypoxia. You're not getting enough oxygen down there. Okay. You can't get through. All right. It's blocked. There's a lot of cars all in the way and you can't get through. So oxygen is not getting to your feet, depending on where it is. This is if it's in the leg and the calf. You're not going to have any symptoms until the artery is about greater than 60% occluded. So you can have an occlusion, patient can have it, and you might not have any symptoms until it's at least 60% occluded. So venous stasis, okay, can increase the pressure in the calf and the leg. So if you have venous stasis, the other direction, the veins, okay, venous stasis, when you're having trouble, it's going to increase the pressure in the calf and the legs. And it's going to also impairs the arterial circulation to the lower extremities too, because you've got that increased pressure in the legs. So it can impair the arterial circulation. And the body can't provide oxygen to the cells. And what happens if that happens? The cells die. So you have decreased arterial oxygenation to the cells. It causes skin atrophy, necrotic subcutaneous fat deposits, the breakdown of red blood cells. That's what you see, all those brown pigments on all the brown pigmentation on someone's skin. That's the breakdown of the red blood cells. You can get a development of venous stasis ulcers, and you're going to have a hard time with healing these ulcers because you need good blood flow to heal the ulcers. Congested venous circulation, increased risk for infection in the ulcerated tissue. So, and then that's a patient can get cellulitis from that as a result. Okay, prevalence. Adults greater than 80 have the highest prevalence. Males greater than females, African Americans and Hispanics have an increased risk. 82% of leg amputations are due to vascular disease. So what are our culprits? It's all the same things. These are our culprits, right? You've learned all about these. And they are things like smoking. This is all very similar to your coronary heart disease. All same thing. Smoking, hypertension, high cholesterol, diabetes. Diabetes is huge. Most patients who have peripheral vascular disease have diabetes. Not all. but many do. Family history of vascular disease. I mean, sometimes you can get a situation. We had a patient, actually, it was Margaret's patient a couple weeks ago, just before vacation. She came in and she had peripheral vascular disease, but I'm going to hold off till we get there. She ended up having an amputation. We're going to talk about what her foot looked like. She did not have diabetes. She had an infection because she had a fempop surgery done, and it got infected. And so because of that, she ended up with a big infection in it. She did not have circulation to the lower extremity. So we need to get that blood flowing down to the extremity. This particular patient, because she did not have the blood flowing down there, that was a huge problem. And she ended up with no circulation. They couldn't stop the infection, and she ended up with an amputation. It was Our Lady in 731 by the window, if my students recall her. Okay, so anyway, you can have a history of DVT. That can also be a problem. Over 50 years old, because they're not as mobile. You can have venous insufficiency, and so you have a problem with this. Prevention, maintain a healthy lifestyle. We all know that. Okay, so we're going to talk about the clinical manifestations of atherosclerosis. I mentioned intermittent claudication. This is an early symptom. This is a patient who starts going out for a walk, and after they're going out for a walk, they need increased oxygen to their feet, and guess what? They're getting pain, and they have to stop. They have to stop. Just kind of like I was mentioning, dyspnea on exertion. You have to stop, but this is pain in the leg. And then there's something called rest pain. These are your signs and symptoms. This is burning when you have inactivity. You can just be laying in bed. And if you're laying with your feet up, okay, you can get the pain. So the pain decreases when the legs are in a dependent position. What's a dependent position? What's a dependent position?
Like dangling off the bed or something like that?
Yeah, down. Right. Dependent is when they're dangling off the bed when they're down. Exactly. Down. Dependent. You need to know that. Okay. That term is going to be used on the exam, but you need to know it anyway. Dependent position. So your legs are down. So you get pain if you're like laying in bed. All right. Is the blood flowing down to your feet? No, now you have an arterial problem. It's flowing straight across. Or if they're elevated a little bit. And sometimes patients will get pain at rest when they're just lying there. They need to literally hang their foot over the side of the bed. Okay? Because they need to get the oxygen down to the feet. In gravity, if they're up, it's going against gravity. The blood is not able to get to the feet because there's an occlusion along the way, and they're starting to get some pain. Does that make sense? Okay, so the pain increases when the legs are up. We need to put those legs down for an arterial problem. Remember I mentioned I want you to know what's the problem. Okay, it's kind of like we're trying to go down to Bridgeport. We're going down Route 8, right? And there's blockages along the way. Are we going to be able to get through? No. So we're going to try. I'm trying to see how I can relate this. We're going to try. We got to see if there's any little, can we ride the shoulder? You're not supposed to. But maybe we can do that because we got to try to do something to get down through. All right. If we turn around and go back up and we elevate the legs and we go Route 8 north, are we going to get down there? No, it's going to be even worse and take us even longer. Okay. So we want to hang our feet over the end of the bed. Now, Brittany had a patient Monday who had serious peripheral vascular disease. and he was having a procedure where they're going to use TPA on his clot in his leg. Well, not so much in his clot, just in his leg, in the narrowing of it. And they were going to try to go in there and open up a clot that was on the side of his leg in that vessel. So we talked about how he needed at times to put his leg down in a dependent position so that he didn't have the pain. I don't know if you remember, Brittany, but we talked about this. I think, Veronica, you were in the room with us too. So peripheral pulses, what are they going to be like? You do remember, Veronica, you were in the room. Yes. So he said he could put his foot down and he gets why? Because the blood and the oxygen are flowing down to the foot. Is this making sense? I hope it is, because it's important. So remember, what direction is the problem? Is the problem where the oxygen and the blood cannot get down to the feet, or is it that it can't get back up to the heart? Arterial problem, the problem is going down to the feet. Venous problem, the problem, we need to elevate the legs because we need to help it get back up. So the pulses, the peripheral pulses are going to be diminished. They might be absent. Now, on our other patient who needed the amputation, what did her foot look like? Her foot was dark, dusky, ice cold, because there was no blood flowing down to her foot. Incredible pain. If you remember, she couldn't even move or turn. And when we touched her feet, I think the whole class was in a room. We noticed, what did we notice? One foot was ice cold and the other one was warm. So these are obvious signs and symptoms. And one was dark, dusky red, almost blue, not quite blue. Barely could feel the pulses. We had a hard time finding the pulses in Brittany's patient because the blood just is not getting down there. That's why we check pulses. Is there good blood flow, right? We want to know about pulses. Is there good blood flow? Or are they absent? So they're going to be diminished or absent. The legs are going to be pale. When we elevate them, oh my goodness, it's not going to be very helpful because we need to get the blood down. Dark red when in the dependent position. When they're down, they're going to be dark red. The skin is going to be thin, shiny, hairless, discolored areas of breakdown. Thickened toenails because they're not getting good perfusion down there. That doesn't mean that if all elderly people who have thickened toenails have poor perfusion. Okay, that does not mean it. They can have thickened toenails from another reason, but it can be due to peripheral vascular disease, as well as other things. Decreased sensation. Do you remember, Veronica, when we touched his feet? When I touched his feet and we asked him, "Can you feel this? Can you?" And he could barely feel the sensation. He had barely any sensation. He couldn't feel anything. Yes, and we had him look away, and he didn't react much. Right? We said, "Okay, turn away. Don't watch me," because he would see me touching. Yeah, I could feel you. He'd say barely, but he was watching me touch his foot. So I said, "Look at the window. Look out the window. Tell me which foot I'm touching." And he had a hard time with the one that had the injury to it. The other one he was fine with and could tell him, he could feel it immediately. So decreased sensation. Skin breakdown is common. Now, what condition? We mentioned the conditions and who's at risk. Who's at serious risk of peripheral vascular disease? We just talked about it, and you guys just had the lecture. It was on the last exam. Who are these patients? Diabetics. Excellent. Diabetics. Diabetics are at serious risk of having black toes. Why? Why black toes? Necrosis, yes. Ischemia, excellent, Megan. Lack of blood flow down to the foot, excellent. So if it's not getting blood flow, it's going to die, okay? It's got to get down and then it's got to come back up. But if oxygen doesn't get down to the cells, they're going to die, and they're at risk of gangrene and amputation. If there's, how many of you guys have taken care of patients who have amputated toes, amputated foot? Most of them are diabetics, not all, but they do have peripheral vascular disease for some reason. It could be any one of those risk factors that we talked about a couple slides ago. They have delayed healing because healing takes place with good blood flow. They do not have good blood flow down to the extremities. And wound infection. Okay, this was a situation I was mentioning my father-in-law who was getting the continuous wound infection, and it can lead to amputation. Wound infection, ischemia, lack of blood flow. Okay, so now these are this guy here, or female, I don't know who, if it's a male or female. This particular limb, this picture is a picture of a person who has chronic venous insufficiency. Okay, so now the problem is with the blood flowing back up to the heart, not down. Okay, so they are going to see lower extremity edema. Because why? Why lower extremity edema? Anybody know why is there going to be edema? Because that blood is pooling.
Nothing is flowing back.
It's not coming back. It's just staying down there. It's pooling, right? The blood is staying down there. It's not able to come back. So it's going to start pooling and you're going to get edema. You can get itchy, dull leg pain. It's going to worsen when you stand. Now, these are the patients that we want to elevate. Okay, they're going to get thin, shiny. Their skin's going to get atrophic, however you want to say. It's going to atrophy. Their skin is going to atrophy, which means shrink and get tight. So it's going to get the skin. Okay, so that's why it's going to look like, whoa, they're swollen, and then the skin is going to get tight around it. You can get cyanosis around the ulcer. Brown skin pigmentation of that lower extremity. It's going to look something like this. There's a couple more pictures, I think, in the book. And the skin will feel hard and leathery because it's atrophied. And it can be weeping. And you can get these recurrent stasis ulcers. They're going to be in the medial or the anterior ankle. Where are they going to be for arterial insufficiency? If someone has PVD, or where are they going to be? PAD, peripheral arterial disease. They're going to be in the feet, right down in the extremities. You might not even get the swelling, but venous, you're going to get the swelling, and the wound is going to be further up around the ankle. Okay, you want to know the difference between the two. Here is a chart. It's in your book. It's right from your book. The location, arterial wounds, serious pain. Okay, Margaret's patient in 731, if you guys remember her, my group, she had serious pain. We could barely touch her foot. And the foot was, she was going for an amputation the next day. The foot was like no pulses. It was just painful because there was no blood flowing down there. Extremely painful. So take a look at this. I don't want to read through the whole thing. I've gone over most of it. Edema with arterial ulcers, they can be absent or mild. You might not have much swelling. It can be significant with venous. Okay. Gangrene, when you see black toes, black area, that's arterial. Okay. It's dying. The cells down there in the feet are dying. Not so much venous return. It does not occur. Pulses, you're going to be able to have the patient will have pulses. The patient will, not this one. The patient will have pulses, but you might not be able to feel them because there could be a lot of swelling with a venous ulcer. But there should be pulses there. You may have to get the Doppler. Pulses for someone who has arterial ulcers, decreased or absent. Okay, so here is.
I just want to point out real quick on the slide for clinical manifestations of the CVI. You have gangrene up there, but on that chart it says does not occur with the venous ulcers. So I don't know.
Gangrene for which one? I'm going back another slide.
Yeah. See right here. Where is it? Unless you changed it.
Gangrene on this one.
Oh yeah, well it was up there when I printed it out. Maybe it's out now.
I did not change my slides. So gangrene happens with arterial for the most part. It should only be last sentence, slide 10. Okay, let's look at slide 10. The last sentence is switched. It's on there. Okay, so gangrene for the most part. Oh, it's switched on yours, the other slide that you were just on. Okay, this one, gangrene, is for arterial for the most part. And rarely are you going to see gangrene. Rarely. It does not occur very often. Do I have gangrene here? Gangrene may occur, it does not occur. Very, very rare. And if it does, it's because probably there's, something else going on. Okay. Or if these ulcers, it would occur if it was an advanced stage, a serious advanced stage where you don't do anything about it. This whole area can start to die. Okay. And then you're going to need an amputation. So when you have serious wounds down here, no matter what they are, they can start to die. Okay. But for the most part, gangrene you're going to see with an arterial problem. Okay. Does that clear that up? All right. Arterial problem. Okay. Blood is not getting down to the feet. Okay. Venous problem. Higher up. What is this? Arterial or venous? Arterial. Yeah. Sorry, Ryan. It's an arterial problem. The black toes. You're going to see this. Have any of you ever seen this?
Yeah, I meant arterial. I don't know why I wrote venous.
Okay. Okay. This is arterial. You're going to see many diabetic patients. Their
I've
toes
seen a
can
piece of it fall off on a patient like this.
Yeah, they can fall off. Exactly right. If you don't do anything about it, you don't take care of these wounds. No matter if it's a venous or arterial problem, they can fall off and you can have serious problems where, yes, absolutely. So what diagnostic tests do we use? It's based on the history and physical exam. They sometimes do an ankle brachial index. And what they do is they check the blood pressure in the ankle, they check the blood pressure in the arm, and they should be relatively the same. And if one of them is decreased, if you have a low blood pressure in the legs, that can suggest a problem with peripheral vascular disease. I had to do some volunteer work when I was a student at Naugatuck Valley, and I did. We had to help out and do these ankle brachial index blood pressures on patients who are at risk for peripheral vascular disease. And the radiologist gave a little talk to us prior, and he said to everybody, he said, I would be out of business if patients didn't smoke. One of the biggest culprits of peripheral vascular disease is smoking. He said, I would be out of business. I always remember him saying that. Okay, so stress test, they can put you on a treadmill to see if you're getting pain in your legs. Are you having that intermittent claudication? They do blood tests to check, they do tests to check the blood flow to see, is the blood flowing through? They can also do Doppler ultrasounds to evaluate the blood flow. They need to evaluate the blood flow. Treatment of the wounds, we want to promote circulation, heal the wounds. Okay, aspirin and Plavix. Okay, these are platelet aggregation inhibitors. They're going to inhibit, okay, stop those platelets from getting together. So clopidogrel is also known as Plavix. That's used for cardiac patients as well as patients who have PVD. Pleto, another medication, and it is a platelet inhibitor with a vasodilator as well. I don't see this one used very much. too much anymore, occasionally. Non-pharmacological therapy. Okay, what are we going to do? Smoking cessation. Meticulous foot care, right? Especially if they're diabetics. My very, very first patient in nursing school was a diabetic patient who had stepped on a tack. It stayed in her foot for 1 week because she wasn't checking her feet. She had no idea that she had the tack because she had no sensation to her feet because she was diabetic. She ended up with an amputation, okay, from diabetes because she was not practicing meticulous foot care. We want to be managing hypertension, cholesterol, diabetes, and our weight. Okay, they have different things that we can do. This is a revascularization technique. It's non-surgical. It's called a PCI, percutaneous coronary intervention. They do this also for the arteries in the heart. And you may have heard of it, the balloon angioplasty. So this is a percutaneous transluminal coronary for the heart angioplasty. And they go in through the artery, they thread it through the artery, and where the blockage is, where there's very little blood flow, see right there, they go in and they put this balloon, and then they blow up the balloon, and they try to move the plaque to the side of the wall right here of the artery, so that now you've got some good blood flowing through there. Pretty cool, huh? They've been doing this procedure for a while, and I'm sure many of you have heard of, in layman's term, they've had a heart attack, whatever, because there's a blocked coronary artery. They go in and they've done the balloon. That's what this is. This is a intervention. It's a percutaneous coronary intervention. And this one is the transluminal coronary angioplasty. They can do revascularization, which is also very similar. They placed a stent. Same thing can happen in the legs and the arteries as can happen in the heart. They go in, look at the narrow area, right? This is very, very narrow. So they go in and they're watching on fluoroscopy. They've got it up on the screen and they can see what's going on, where the narrow part is. They go in, they have a stent, they open it up, okay? And they place the stent there. And then they come back out. So this keeps it open. How many times have we heard that a stent was placed for someone who had a heart attack? Surgical treatment, this is where they go in and they do a fempop. You may have had a patient, I know some of my students have had patients that have had fempops. They're femoral popliteal. It's a bypass, just like in the heart. It's a bypass graft. So what happens is they find the bad area. See the bad area? They locate the bad area where the blockage is, and then they put a graft around it to bypass it. They take a graft from another artery in the patient's body, and they move it and they attach it and they do this bypass graft. Now, our lady who was in 731, who had the ice cold foot and was going to have an amputation, she had this done a few years ago. She ended up with an infection in it. This got infected. So it obviously didn't work anymore. It wasn't working. And so it was kind of like, a mess. It was kind of like a mess. So she ended up having
Right, Mike is on.
Yeah, if you guys want to, mute. Thanks. So anyway, she ended up having to have an amputation because they could not go back in because this graft got infected. Complementary therapies, what are we going to do? All the same things. You could take a look here. Okay. Any of these, awesome. Promote circulation, reduce stress, aromatherapy, biofeedback, massage, herbals, all these things. Vegetarian diet, low in fat, but make sure the patient's getting their nutrients, their vitamins, their supplements, and their proteins. Okay. Some people who do not eat meat are at risk of being deficient in protein. So make sure that our patients are also getting good sources of protein, and that's the nutrition class. I'm sure you learned all about that. Complications of peripheral vascular disease, atrophy of the skin and the underlying muscle, delayed healing. Why are we getting delayed healing in these wounds?
Poor perfusion.
Poor perfusion. Excellent. Okay, because the blood's not getting down there to heal it. Pretty nasty looking wound, right? Wound infections, and then wounds can get infected. Ischemia, lack of blood flow, tissue necrosis. This is getting there. Gangrene, and then that can lead to an amputation. So these are all potential complications. They don't necessarily happen together. You can just have ischemia. You can just have tissue necrosis without having amputation. But if you have all of them, you can end up most likely with an amputation of a toe, a foot, and then a below knee amp, and then an above knee amputation. Okay,
Can that lead to
patient goals.
osteomyelitis?
Osteomyelitis. We're going to talk about that real soon. Yes, that can also happen. And that's where an infection settles in the bone. So the goal is to increase the arterial blood flow. What are we going to do? We're going to lower extremity below the level of the heart if it's an arterial problem, right? Dependent position. Does that make sense to you guys? Do you understand that? So we're going to lower the extremity below the heart if it's a peripheral arterial problem. So the first thing you want to do when you're reading test questions and reading a patient's chart, not just for the test, is differentiate. Is this an arterial problem or a venous problem? Because if it's an arterial problem, like your guy, Brittany, and Veronica, you were in the room too on Monday, do we want to elevate his legs? Do we want to put him up? What's going to happen if we put his legs up? A patient who has an arterial problem, what's going to happen if we put their legs up?
It could pull the heart.
They're going to get no oxygen. But what's going to happen to him? What's he going to feel like? The blood won't reach his feet. Pain. Excellent. He's going to be in pain. He's going to, and as Veronica, you mentioned, he said, yeah, I need to hang my legs down off the side of the bed. At times, these people get pain when they're laying in bed. They're laying in bed because their feet are not down and the oxygen is not flowing down to their feet. So I've said it about 10 times so far. Make sure you know which direction the blood needs to be flowing. Where's the problem? Is it going down south, arterial problem, down root 8, or is it going north, up root 8? Okay, going back to the heart. So the patient goals for peripheral vascular disease, increase arterial blood flow, decrease venous congestion. Interventions, if it's a venous problem, notice these are bold. Arterial, so we want to sometimes put the foot down. Venous, we want to elevate. If it's a problem with, where the blood is not coming back up because the legs are in pain, one of the seniors, I think she's a senior this year, she's a dancer. She was, I believe, a professional dancer. And she told me, she said when she would get done dancing, they would literally sit on the side and on the side of the wall and put their legs straight up against the wall. Now, some of you who have danced also, and also may have children who are dancers, some of your children, if you've ever done that, you know that you're not at risk, but a complication, it can be a little bit painful, is because those legs are in the dependent position all the time. When you're done dancing, you want to sit on the side of the wall and just put those legs straight up. Okay, so we want to discourage, I know soccer players, yeah, because you're standing all the time. People who are standing all the time. And if you are someone who's in clinical and you're standing all the time and your legs hurt, okay, when I think you guys all know I was a pastry chef and I was standing all the time, my legs hurt. I would literally come home and just I'd sit on the couch and put my legs up against the side of the couch straight up because I needed to get that blood back to the heart. I don't have an arterial. I have a venous problem with them returning. And even now, when I'm, oh yeah, we're waiting for, you're waiting for treats. Yeah. I did bring treats to my clinical group, Valentine's Day. Anyway, when I'm standing for long periods of time, because I'm cooking the holidays and I'm not sitting down all day, if it's early in the day, not an evening holiday, but like Easter or something, I will go out and take a walk, and that will help relieve the pain in my legs. And that's a venous problem. So the compression hose helps getting those legs elevated and taking a walk. So all these things discourage the standing and sitting for long periods, encourage ambulation. So patient teaching, here's the difference. Arterial, protect them from trauma, smoking cessation, increase fruits, vegetables, whole grains. Ambulate, this is ideal. 30 to 60 minutes a day, 3 to 5 days a week. This is the recommendation from, I'm trying to think what group it is. It's one of the groups that it's from the CDC. Sorry. It's from the CDC. The CDC's recommendation is patients should be ambulating 3 to 5 days a week for a total of 150 minutes a week of exercise. So this is not just for our patients. This is also for us. Keep the extremity lower than the heart for arterial problem. Venous problem, protect from trauma. Apply those anti-embolism stockings unless the patient has a DVT. But for prevention, even if they don't have a DVT, they're just good to help promote venous return. Encourage daily ambulation, avoid standing for long periods of time, and elevate the legs above the heart. Okay, any questions so far? Can I keep going? We got half an hour to do osteomyelitis, and hopefully we've got a little activity after if there's time. A case study if there's time. Okay, osteomyelitis. Can someone have PVD and DVT and a DVT? Or you mean both? Yeah, you can have any or all of those. Yep, you can. It just depends on the individual. Yeah. Some people have it all, unfortunately. Yeah. So what is osteomyelitis? Osteomyelitis is an infection in the bone. So it is caused by an infection. Okay, an infection can directly enter the body, and it can settle in the bone. It can settle in a nearby joint. So if an infection gets in somehow, how can a patient get an infection in their foot? Bacteria. Bacteria gets in somehow. It can get in like an infectious organism is directly introduced into the bone. You can get a cellulitis, but the organism has to get into the bone, hence the name osteo. Okay, right? What does osteo mean? Bone. Okay, osteo means bone. So it's a infection in the bone is really what it's all about. It can begin in the bone, and then if the injury exposes the bone to germs, all right, you can get an osteomyelitis. So it's an inflammation of the bone. Who's at risk? Smokers. Of course, smokers are at risk of like everything, right? Okay, so smoking is bad. I seriously understand. It's a habit. It's very, very difficult to control. No judgment, I'm not passing judgment. I'm just saying that smokers are at risk for many conditions, unfortunately. And as that radiologist said, he goes, I would be out of business if it weren't for people smoking. He said 90% of my patients are smokers. Poorly controlled diabetics. By the way, Veronica and Brittany, and those of you who saw the patient in 718 on Monday, what else did we notice about that patient? He was a diabetic who had the peripheral vascular disease. His eye, yes. And as soon as you walk in the room, he basically didn't have an eye. And so, I had asked him what happened. No, I didn't come out and just ask him what happened to his eye. I think we were talking about diabetes. And the first thing he said to me was, this is a result. My eye is a result of poorly controlled diabetes. You guys weren't in the room when I went in to see him before you had arrived. And he said, this is a result of poorly controlled. Yes. So his eye as well as his peripheral vascular disease. His sugar was 44 when we first checked it. And he said that was normal. Yeah. He's very uncontrolled. Yeah. Up and down. Okay. Illegal drug users, they share needles. They don't clean the skin. Okay. It's an infection that gets into the body. And if it's near a joint, if it's near a bone, it can get into the bone. So medical conditions that affect the immune system, cancer. Okay. Because they have a compromised immune system. They can't fight off infection very well. So do diabetics. So do patients who are on steroids. What are the symptoms? Symptoms of infection, basically. There are some articles that I posted because there is nothing in the book on it. I don't know if you noticed or not, but it's an exemplar and there's nothing in the book on osteomyelitis. So I posted some articles for you and we're going to do a little case study. Fever, swelling, warmth, pain. What does this sound like? Signs and symptoms of infection. Bone pain. Okay. You can have bone pain with this. And you know what? You might not have symptoms either. And fatigue. You can have fatigue. You can be extremely tired. Sometimes no symptoms. It's hard to distinguish from other diseases. So they might not always know. They could see that there's an infection and you can get a red swollen arm as well. And it might not be osteomyelitis elbow. Just because you see this picture does not always mean that you have osteomyelitis. It's one of the potential diagnoses, but not necessarily. It can be a cellulitis or other things, bursitis. It can be lots of things. So, okay. So sometimes it's hard to distinguish. This is true for infants, older adults with compromised immune systems. What are the complications? Osteonecrosis, where you're going to get bone death. So that's where you're going to get the surgical debridement. You need this surgical debridement for the antibiotics to work. So no one wants to lose a limb. No one wants to have an amputation. But sometimes when we keep those, areas, the necrotic areas, the infection is only getting worse and worse. So the infection can impede the blood circulation within the bone, and then it just can get worse and worse. Septic arthritis. One of our patients, one of my students, one of you guys had a patient with septic arthritis on Monday. Infection in the bone can spread to nearby joint. I think it was your patient, Margaret, who had the septic arthritis. So that's what happened to her. Impaired growth. Children who get the infections, if the infection is in the growth plate, which is at the end of the long bone, that can impair their growth. So we don't want that to happen. So they can also be conditions from diabetic foot infections. That is the leading cause of non-traumatic lower extremity amputations. So that is complications from a foot infection. And about 85% of amputations result from an infected foot ulcer. So if you have an infected foot or an infected limb and it doesn't resolve, you can end up with an osteomyelitis and you can end up with an amputation, unfortunately. So that's why when we have infections, we have to be really, really careful that we take care of them and we get on an antibiotic. because very, very rapidly these infections can spread to our blood, which goes throughout our whole body, and we can become septic, what's called sepsis. And then people die from sepsis all the time. And many of your diagnoses are on patients who have sepsis. So from one form or another, UTI, some type of infections gotten into the body. So one more thing about bone infections, an infectious organism is going to get directly into the bone. So often that can happen from trauma. So patients who break bones from trauma, especially the ones that are compound fractures where the skin is opened, or motor vehicle accidents where you break a bone. You want to make, the medical profession wants to do their best to make sure that that does not get infected, because trauma is another reason for someone to get an infection. Okay, so amputation, what's an amputation? It's a surgical remover of part of a limb. So it can be a finger, it can be a toe, it can be the foot, and it can be all the way up to, in this case, this picture, a below knee, a BKA, a below knee amputation. There's also an AKA, above knee amputation. The causes, what causes? 82% are related to poor circulation. Okay, so is that an arterial problem or is that a venous problem? Poor circulation. Most often it is in this case, that leads to, it's an arterial problem. Right. Sometimes we talk about poor circulation as being a venous problem too. Let me just say that. Poor circulation is kind of a generic term, because we're just saying that your blood is not flowing around well. If it leads to amputation, for the most part, it is going to be an arterial problem. But truly, poor circulation can also be a venous problem, where the blood is just not circulating very well. It's circulating poorly. Okay, diseases: peripheral vascular disease, diabetes, thrombus, a clot, because the clot's going to occlude the circulation, right? You get a clot in that artery or in the vein, it's going to occlude. If it's in the vein, if it's in the artery, they're both serious problems. Okay, so a thrombus in the artery can travel, huge problem. A thrombus may block off the circulation. The woman I was telling you about who had the infection in her graft. Okay, so because of the infection, that wasn't necessarily a clot, but now she's got a blockage down there. So she's not getting good perfusion. Osteomyelitis can be a cause of an amputation. Oh, actually, we're talking about causes of amputation, not causes of osteomyelitis. This particular woman who had the problem with the skin graft or her bypass graft that got infected ended up going for an amputation the very next day, on Tuesday after our clinical. So she ended up with it because it had failed. So, and hers was a result of peripheral vascular disease. Injuries, especially in the arms, we have to be careful. We get an infection in the arm, it goes into the bone, it can overtake the whole arm. We can end up with an amputation. So what we do is, another cause is surgery to remove tumors from bones and muscles. Rehabilitation. So this is a serious problem with self-image, body image. We want to be, helping these patients out as best as possible. They have a permanent disability. And I'm sure some of you have had patients with amputations. So some of them are very strong. They have a lot of, if they have had amputations in their lower extremities, they're now using their upper extremities. And their upper extremities are very strong, and they're able to transfer themselves into a wheelchair or into, the bathroom and to the toilet, wherever they need to go, they can transfer themselves because they've compensated by having such strong upper extremities. So it's truly a self-image problem in the beginning, self-care. Not everyone can do that. Our patient, it was Margaret's patient, she was extremely worried about how she was going to handle having this leg amputation. And it was extremely depressing for her, as you can just well imagine. Mobility is obviously an issue, and it's an interdisciplinary team approach that we have to take in helping these patients. Pain management is huge, especially in the beginning when they're post-op. They can have phantom pain. They still feel like they have pain and they have sensation of pain below the level of the amputation. It's like where that foot was that was amputated. That's called phantom pain. They still feel like I have pain in that foot, even though that foot is not there. Wound healing and stump care. We are going to be doing that. I'm trying to remember. We had a patient who had a wound vac. Now that's one of the frequent things they do is they put a wound vac on the area of the amputation, which on this particular patient would be down here. It all depends on the patient. But that is the new thing now is we have wound vacs on them. Nutritional counseling to promote healing and health. So important. Exercise to promote muscle strength and endurance. Okay, so we want to be helping these patients reach their maximum independence. We've all seen and heard about patients who are now running marathons, who have amputations, and they have prostheses. They need to have them fitted properly. If they're not fitted properly, it's not going to help them. They can also get infections. I've seen infections that have happened, patients who've returned because they've had an infection from an amputation that did not heal properly. Okay, the use of assistive devices. You know, maybe they can use a walker. They do have one leg. Maybe they can use a crutch. So it just depends on the patient and what level of functioning they're at. Are they young? And this is an unfortunate situation. And the rest of their body is very strong except for that part. So, you know, I know the Boston Marathon, many people ended up with amputations. That was several years ago. I think it was back in 2012. Was it something like that? 2011, 2012, 2013, somewhere in there. Very, very sad situation. And many people were running that Boston Marathon with prostheses, and they were able to complete it. Unbelievable, right? Okay, so we want to adapt the home environment, all that. And we, of course, want to provide as much emotional support as we possibly can because there's some grief there. They're grieving a body part that is no longer with them, that they no longer have, and they have to readjust their whole life in their whole new body image because of this amputation. Okay, great. Great job, everyone. Now we finished that. Any questions? Now I'll take questions. Wow, we actually have a couple minutes. This is fantastic. All right.
Professor, you have massage as a non-pharmacological therapy or a complementary therapy?
For what?
Let me see where it is. It's a while back. It's under like aromatherapy. There you go.
Right here.
You don't want to do that when you have a DVT, do you?
Well, this isn't necessarily, no, you absolutely do not want to massage an area that has a potential DVT. And, you know, you really don't know if a patient has a DVT. So I personally do not massage, and we might have some massage therapists in the group here. I personally do not massage anyone's legs because you don't know if there is a DVT or not. But just complementary therapy, massage is in there to promote circulation. Not if you have a DVT, but to promote circulation to the hands, You know, when you go for a manicure, pedicure, they do a little hand massage. That's just to promote the circulation. And I don't let them rub my legs, by the way. But yeah, you do not want to massage the area that has the potential for a clot. Absolutely not. You're correct. But it's just to promote circulation.
Okay, thank you.
Sure. Any other questions?
Professor, I have a question. Are patients who've had knee replacement or hip replacement at risk for osteomyelitis?
Not necessarily. They're only at risk if they get an infection.
And in osteomyelitis, will that infection show up in the lab results?
Well, how would it show up in the lab results? How would an infection show up in lab
White
results?
blood cell count.
Exactly. The white blood cell count's going to be elevated. And that's one of the first things they do.
So
They do a white blood cell count.
Right. The reason I ask is because my sister recently had double knee replacement, and the physical therapist thought she may have an infection in the knee. But I saw her recently, and her knees didn't show any signs of infection on the outside. Like the scars looked well. There was no redness. There wasn't any pain. And her recent lab results showed no elevated white blood cell count. So I was just curious why the physical therapist would think an infection there.
Well, you said when you visibly saw it and you saw that there were no obvious signs of infection, she's not running a fever. You said there's no redness. The wound looks like it's well approximated. It's healing. White blood cell count sounds to me like there's no infection. Perhaps because is she having a lot of pain and she's not able to walk very well? Maybe she's not progressing in that area. So she's thinking that, you know, the excessive pain could be from infection, because when we have an infection, we have an excessive amount of pain. But to me, from what you're telling me, does not sound like it, that she has an infection. And if white blood cell count is normal, I would say there's probably not an infection.
Right. Okay. All right. Thank you. I was just curious because it did say you had sometimes no symptoms, hard to distinguish from other diseases. And I wasn't quite sure.
Well, not necessarily blood work. I mean, the obvious. Yeah, you
Okay.
can have no symptoms. You know, sometimes, I mean, this happens all the time. You know, providers are not sure what's wrong with us. What's the first thing they do? Because we have maybe, you know, symptoms are okay. What's the first thing they do when we go to the doctor?
Blood work, lots of it.
Blood work, exactly. Because blood work is, you know, it's like vitals. You know, blood work's going to tell us, okay, is their blood pressure up? Is the pulse up? What's going on? Do they have a fever? Right there is going to start to tell us some things. But when we need to get a little more invasive and we need to get some blood and we need to check that. So if the white blood cell count is good, chances are everything's fine. Sometimes we have symptoms and all the blood work is fine. So, you know, it's kind of like a catch-22. And I've had my provider, who I think is an excellent provider, say to me several times, I have no idea why this is happening. And good for him. Kudos for being honest with me. You know, I have no idea. You know, I can't pinpoint it. All the tests are coming back negative. How many times have we heard that, right? Everything's negative, but the patient's still having symptoms and they can't figure out what's wrong.
Yes, exactly. Thank you so much.
Great. Good questions. Good discussion. Okay. I have a little scenario for you. Okay. The situation is Lucy. Lucy's our patient. She's 70 years old. She's a retired secretary. You know what? Let me see if I can put this. I'm going to copy this and put it in the chat so you guys could see it for my visual learners. Hold on. Sorry. Okay. Everybody see that? Lucy's 70. She's retired secretary. Hold on. Okay. Recently, she's been experiencing pain when taking morning walks. She smokes 2 packs a day. until she quit 5 years ago when she retired. She has diabetes, hypertension, high cholesterol, chronic kidney disease. She eats relatively healthy foods, but most often, but she enjoys a big bowl of ice cream every night. Her leg pain is getting increasingly worse, and her legs are cool and dark red when she returns from her walk. Lucy decides to visit a doctor for her condition and is diagnosed with peripheral vascular disease. My questions to you: what are Lucy's risk factors for peripheral vascular disease?
Hypertension and smoking?
Hold on one second. Yeah, I would say hypertension and smoking. Hold on just one second. All right, hold on. What do we have? Smoking, hypertension. She's retired, so she's less mobile. Excellent. Very good. What else besides smoking, hypertension? Anybody say it? Diabetes. Excellent. Yes, diabetes. Very good. High cholesterol. What about the high cholesterol? So yeah, her sedentary occupation. All right. Now she's trying to take walks, right? Smoking. She's past smoker. I mean, it's great that she quit, but she's past smoker, diabetes, hypertension, high cholesterol. Chronic kidney disease can impair her blood flow. Yes, it can. Yep, we can add that. So does Lucy have an arterial or a vascular problem? Arterial. Excellent. Excellent. Arterial problem. What signs and symptoms of PVD does Lucy have? Yes, and what's that pain with walking called, Kimberly Cruz? What's that called? You got it. You guys are so good. Okay. Dark, cool, pain, cool, red, dark. Yes, dark red. Okay, the color of her legs. Claudication. Excellent. Claudication. That's the problem. Yes, intermittent claudication. That's when she walks and she gets the pain. Leg discoloration, leg claudication. You guys are so good. Okay, now if we had time, I would have you create a teaching plan for Lucy to improve her condition. So what are we going to have her do? Right here in the PowerPoint. Put her legs down. Okay. Put her feet in dependent position when she starts to get pain. Yes. Quit smoking. Shorter walks. We're going to tell her to stop. Take frequent breaks. And you know what happens? Then after a short while, they can go a little bit further. Okay. They're going to be able to go a little bit further each day. Hopefully, it depends on how serious a problem it is. I mean, she may need some type of treatment or something, some type of intervention. We really need to see how blocked is it. Yeah, she already did quit smoking. The damage was done, but yeah, so that's good. Monitor her diabetes. Make sure that she's watching her diabetes. And she's, checking her feet and all that and managing her sugars and her diet, right? No eating ice cream, Libby? Goodness, that's one of my favorites. Well, she really should watch her ice cream. You're right. Right. Because what's the problem with her eating ice cream? Maybe once a week. Yeah, not every night, right? Not every night. Okay. Control the cholesterol if she's prescribed medications. Yeah, she needs to maybe take a statin to control her cholesterol. Okay, then she can maybe eat a little bit more. Yeah, that's a problem. A small bowl of ice cream? Okay. That's hard to do though when you love ice cream. Trust me. Ice cream could be sugar-free. Yeah, that's a great suggestion. Okay, because that's going to help her with her diabetes, sugar-free, right? Cholesterol, she has high cholesterol. Hopefully she's on a statin. I don't know if she's on a statin or not. So good. High sugar in the morning. Yeah, we got to watch that. Excellent, excellent, excellent. Okay, what questions do you have for me? We have a couple more minutes. Anything about the medications? Questions do you have about the medications for me? You need to know the medications. You need to know the risk factors. So who is at risk for these diseases? Because they're very common. So we want to be talking to our patients about prevention if they are a patient who's at risk. And we want to talk to them about, we don't want to tell them, you're at risk of an amputation or you're at risk of an infection, which can lead to an amputation. However, with diabetics, it's so important for them to be checking their feet and watching their sugar. So many things can happen. So we want to be identifying the patients who are at risk so that we can help them and give them some patient education. We want to know the signs and symptoms. Can you recognize a DVT and who is at risk for it? Know the anticoagulant medications. Warfarin, apixaban, enoxaparin, heparin. Very important to know. Know the major side effects in a teaching plan. Know the treatment for DVT. Know the lab tests. Okay, which one is INR affected by? Okay, and which one is it not affected by? So that if there's a distractor and says INR, I want you to be thinking, does this apply to the anticoagulant? What is the normal value for a client who should be anticoagulated that is on warfarin? Okay. What's the antagonist for them? Okay, so I'm going to end the discussion with a question. If there's no more questions, this is a first for me to end early, right? Wow. Okay, so the antagonist meds for Xarelto and Eliquis, their current are not anything that is like that we talk about and nothing really known out there. There are some things in the emergency room. You do not have to know the antagonist for Xarelto and Eliquis. It's case center, but you don't have to know that because it's not like advertised yet in the book. Let me see if I can find my poll. I have a question for you. Hold on, if I can get the poll up. I have it up. I just have to. You guys see the poll? It says 1 or 2. Why does it say 1?
We see it, but we don't know what the answers are.
There are dietary restrictions when a client takes apixaban. Apixaban is Eliquis. So 1 would be yes, and 2 would be no. Okay, there are dietary restrictions when a patient takes apixaban, which is Eliquis. 1 is yes, there are, and 2 is no, there are not.
It's great. Yeah. I just don't understand this last since I think a typo there.
Okay, now I'm trying to get back to my chat. Where is that? Sorry about the yes or no. I don't know why it says 1 or 2. Sorry about that. I'm not good at the chat. I mean, I'm not good at the poll. Ann Lane says, I had a patient who had it marked in the chart that he had a DVT with a lot of his symptoms, but a lot of his symptoms aligned with PAD. Okay, would a provider use these terms interchangeable? Great question. Yes, they use the terms PVD and PAD interchangeable. Another thing that they often do for a DVT sometimes is measure the extremity. I have honestly never seen it. And you might hear someone say, oh, you know, measure the extremity as an intervention. That would be a correct intervention. However, I've never seen that. We don't do that in real world. We don't measure the extremity because sometimes they don't have edema. They do, they can, but they don't always. So the NCLEX uses trade names? Really? I was told that the NCLEX uses generic names. So we will see. You know what? I'm going to have a discussion about that with our team and see if we can use both names for the exam. I think we really need to find out if the NCLEX does use trade names.
Which one would be the trade? I always get confused with that. Is Eliquis the trade name and or vice versa?
Eliquis is the trade name. Apixaban is the generic name. Yeah.
All right, thanks.
You're welcome. Okay. Great discussion, everyone. The answer is there are no dietary restrictions when a client takes Apixaban. Okay. What medication are there dietary restrictions on? Warfarin, excellent. Excellent. Same drug. Excellent. Okay, you guys are great. So with that, I'm going to end.
Thank you. Awesome discussions the past 2 days.
Great. Thank you. And let me know if you have any questions.
Professor,